Thank you very much for that kind introduction. I wasn't quite sure about the crowd, so I sort of made a little bit of a match of a few things. So just start the slides, okay. Really happy for this opportunity to give this talk. And I think I just wanted to give an overview on my topic, which is on colorectal cancer. So the timer is, so that I don't, the timer is here. Okay, excellent. So, all right. So let's start with the burden of colorectal cancer. I think it's, Dr. Eliana had already talked about it. I think it is a very common cancer, all right? It's the second commonest cancer in Malaysia. It's the commonest cancer in male and the second commonest in women. So for sure, colorectal cancer is a very important health burden in our part of the world and worldwide. But what is even more disturbing is the fact that if you actually look at the staging or the stage at presentation, you can see here that from 2012, maybe I'll move here, from 2012 to 2016, as opposed to in the earlier years, you actually see that the percentage of stage 3 and 4 is actually higher. All right, so in other words, despite the fact that you would have thought that with this day and age that you would have picked up these things earlier, actually in fact that is not the case. These are some of the risk factors, which I'm not going to go through too much, but you can see that it actually applies to a very large proportion of the population. And this is just your average risk group. I'm not talking about people who are at high risk groups. These high risk groups, those with a strong family history of colorectal cancer and gene mutations like the APC gene mutation or the HNPCC, inflammatory bowel disease, some other conditions, these people should not have, these are not average groups. These people fall into a different category and they should just have their screening colonoscopy straight as according to guidelines. But I'm not going to talk about that. So this is from the national prevention strategy that Dr. Liana talked about, which tells you why does it matter. Well, if you can see here that if you were picked up at stage 1 disease, your 1-year survival is 87 and 5-year it's 75, so at least 3/4 would expect to be cured. But once you get down to stage 4, which is where most of our patients present, that actually goes down to 17% in 5 years. I wanted to share this case actually just to set the scene. Can we play it? Yeah. This is one patient that I saw. Just thought I wanted to show to you, yeah.
Paling pertama bila saya merasa sakit seperti usus itu dipulas macam ada orang perah di kain, begitu rasanya usus kita diperah. Disebabkan itu saya terus jumpa dengan doktor. Saya ingat lagi saya pergi KTJ Tawakal dan doktor melakukan X-ray dan menyatakan bahawa saya mengalami appendix dan mereka mahu melakukan pembedahan straight away, tapi saya minta tempoh, saya balik ke rumah dan esoknya saya cuba dapatkan pandangan kedua daripada doktor di UMSC specialist dan saya tunjukkan diagnosis dan juga X-ray punya filem tu kepada doktor berkenaan dan doktor berkenaan bersetuju dengan pandangan yang diberikan oleh doktor KPJ bahawa saya mengalami appendix. Tapi waktu itu saya jelaskan kepada doktor ianya tak mungkin appendix kerana selepas itu kesakitan itu sudah tidak ada. Dan pada saya, sebab saya ada sedikit ilmu mengenai appendix, tahu saya appendix ini kalau kita sakit dia akan berterusan, dia tak akan hilang. Tapi waktu itu doktor itu menjelaskan bahawa mungkin saya bernasib baik kerana sistem makanan yang berada di appendix itu sudah keluar dengan sendirinya dan bengkak itu sudah mengecut dan jadi seperti sedia kala. Selepas daripada pertemuan dengan doktor pertama tu, saya ada merujuk pada tahun kedua. Dia berlaku setiap tahun daripada 2016. Paling pertama bila
I think that's probably not possible. Okay, I think what I wanted to show to you actually, this case as a recap, is that this patient actually presented with abdominal pain, and then it was diagnosed as appendix, but then it went away, and then after that it came and went, and this went on for 2 years, and then he went to see about 3 doctors. Was appendix diagnosed, and irritable bowel syndrome was diagnosed in this patient, and then after that then he developed some rectal bleeding, and then he had some weight loss. So and then finally he presented to me, and then I did a colonoscopy. Okay, so but unfortunately when I did it, because after all it was 2 years after he developed symptoms, it was already stage 3. Okay, so he underwent an operation and he underwent chemotherapy after that, but he survived for 2 years and then he died. Okay, this guy's some sort of celebrity from Academy Fantasia. Oh, you know him? Oh wow, okay. Yeah, so I don't know much about Academy Fantasia, so I didn't know, but I was told, and that's a very sad outcome. And actually the problem wasn't even him, it wasn't even so much that it was him that failed to make the diagnosis, but it was also the doctors as well. And I think that's something that we really have to think about. I wanted to show a second case. Now this patient is a doctor, so probably she had a bit more awareness. She came to me with rectal bleeding, and I said, well, maybe it's hemorrhoid, you're quite young. But she was very clear in her mind. She told me, no, it's not right, she said. The bleeding is not normal. And sure enough, she had this precancerous polyp, all right, this is already showing high-grade dysplasia. So I removed it, and it's gone. All right, there's no need for surgery, nothing, no need for anything. So you pick it up at this stage, you essentially prevent. You're not even talking about cure, because it's not even like at a cancerous stage yet. This is prevention, and that is colon cancer. Okay, so I just wanted to highlight the difference and why I still feel very strongly about colorectal cancer, early diagnosis and screening. So I just wanted to say, so for example, if you even ask like my medical students or primary physicians, chronic constipation, do you think this is a common symptom for CRC? Who raise your hands? No one wants to answer? What about change in bowel habit? Is this common symptom if you don't have any other features? Yes or no? Yes. Okay, all right. Iron deficiency, is that normal in male? Ever? No. Never, all right. And what about this intermittent bleeding? Like, do you think you can get intermittent bleeding if you have cancer, or you think the bleeding should be there all the time? Yeah, exactly. So these are some of the things. For example, people with chronic constipation usually don't have cancer actually. So because if not, we'd be like screening like 10 to 20% of the population. So this is the difficulty, all right? It can, some of the symptoms are common, but that doesn't mean that all of it points to colon cancer. So where are we going to do the screening? Change in bowel habit on its own can also alter. You go away, you have slight alterations in your gut microbiome, then of course you may have some changes. But if it's prolonged, if it's abnormally long, like for a few weeks, then you should start thinking about it. And then we talked about these two. So just to tell you that it's even symptoms alone are not easy, but these are some of the things where you really start to think, you know, could it be that this patient have got features of colorectal cancer. So and I think once you have them, and I think this is probably more geared towards primary care level, then the idea is that you really should be sending these patients for an expedited colonoscopy. But can we get an expedited colonoscopy? And that's going to be another thing that we're going to be talking about just a little bit later. Right. So actually my talk is going to be not so long, more that I just wanted to set the scene. So the ones that I talked to you about were patients with symptoms, all right? So like for example, my patient, they actually had symptoms. One had abdominal pain, followed by weight loss, followed by rectal bleeding. One actually had rectal bleeding, all right? Those are symptomatic patients. So those patients should go for colonoscopy. They shouldn't be undergoing anything else, all right? But what about screening? Okay, so what are we talking about when we talk about screening? Yeah. So essentially screening is when you don't have any symptoms, right? So those are for asymptomatic population, all right? So you actually pick up the cancer or precancerous lesions before you have symptoms. Now colonoscopy is only one of the tools, and we'll be talking about that in a minute. All right, so why is colon cancer so good for screening? All right, because all of them arise from these adenomas, we call them, all right, or polyps. These are the precancerous lesions. And the progression takes anywhere between 5 to 20 years, approximately 10 years on average, okay? And the concept is you can pick it up, or at least pick either precancerous or early cancers before you get the symptoms developing. And I think it's the only truly preventable cancer rather than, other than cervical cancer. Because cervical cancer, you look for this cervical intraepithelial neoplasia, and you can do your cone biopsies, ablations, and so on, right? Whereas in colon cancer, we can remove the polyps, okay? Breast cancer is not like that, all right? Because when you feel a lump, that's cancer, okay? That's not preventing the cancer. But in colorectal cancer, you can actually prevent the cancer. So what are the screening methods that we use? Well, I've talked about colonoscopy, all right? Of course, that's the preventative part, but of course it's invasive, it's expensive, and the one that's often used, of course, is the fecal occult blood testing. Last time it used to be guaiac-based, but now we call it the FOBT and FIT, and Dr. Alina will probably be talking about that. That's actually offered in the Klinik Kesihatan. And that's one of the things that me as the coming president of Malaysian Society of Gastroenterology and Hepatology, we want to try and see how we can help out with the next step, which is to offer colonoscopies in those who are positive. So what do I mean? These are people where you don't see bleeding. Okay, the bleeding is microscopic. You test the stool, all right, and if it's positive, then you send them for an urgent colonoscopy. And they found out, of course, some cases are not significant findings, all right? Some of it is just going to be something like maybe a little bit of hemorrhoids or whatever. But they do have a significant portion who do have polyps, which can be removed, therefore prevent the cancer, and they did pick up some early cancers as well. But the problem, unfortunately, is that the pickup rate from the FIT positive is very, the people who then went on to have a colonoscopy was very low. In other words, people were having their FITs, but in the end, the number of people who then went on to have their colonoscopies were low. And I think that's another big problem that we have to solve, the big gap. Okay, so this is how the FIT is being carried out, okay? And the patients who are positive are then sent for screening colonoscopies. And this is what I meant to you, that all of the colon cancers start from this adenoma, which then go on to cancer. So if like in the case that I did, I removed that adenoma, you don't get any cancer, all right? So like in this case. So, however, there are so many barriers, and this has already been addressed in many, many other cancers. All right, and there's so many, a lot of it is this fear and acceptability and all sorts of things really that I won't talk about in too much detail here. How are we going to address this? Well, I think we know education and awareness is still very, very important, of course, and these are some of the things from the National Colorectal Cancer planning, strategic planning, which is planned, but the implementation are things that we have to work on, and this idea of a navigation pathway. Now it's FIT positive. Now what? You go to the nearest KKM hospital and the waiting list is 4 months, 6 months. I had a patient who told me he had iron deficiency anemia. Okay, I met a cancer survivor during one of my health campaigns. His hemoglobin was 8 in August. He finally got his colonoscopy in December. All right. So, we can talk about colorectal cancer screening. If we don't have the facilities, if we don't have the good pathways, then I think that's the other problem, all right? And so I think these are some of the things that I'll be very, very happy to work with the National Cancer Society and Ministry of Health in terms of how we can try to bridge this gap. So I'm going to stop here by just telling you that I hope, I'm sure we all know that CRC is a very common cancer and it is a very important health burden. And I think the problem is that they do present very, very late in the disease. and that it is very, very important to detect them earlier, because by detecting it, it really can save life. It also saves costs. You don't need to have the surgery. You don't have to have the expensive chemotherapy, and not to talk about other things like quality of life and work, the workforce, disruptions and so on and so forth. And benefits of colorectal cancer screening is well established. It's still not carried out even in the most developed countries, but for example, places like UK and Australia have already done them. And with that, I thank you.